So let me be clear. A supersaturation, well, I'll say this. Supersaturation is done manually or evaluated manually by essentially running this experiment where I have a sample of urine, okay, and that urine has dissolved solutes in it. And in that urine, I essentially place, let's say, a solid a solid sample of calcium oxalate. And if I see that this calcium oxalate grows in size, right, then I know that this sample of urine was supersaturated, right? The amount, after I let it equilibrate, the amount of precipitate that forms would imply that this urine contained more than the solubility point of calcium oxalate in it. And so the solids grew. Now, if this solid shrank, that would imply that the sample was not supersaturated. That is, the solid will progressively dissolve into the urine and make it contain more dissolved calcium oxalate. That would be undersaturated, okay? Now, we, in fact, don't do this experiment when you send a 24-hour urine. We essentially model this effect using a computer program. So people will describe that as an in silico test, right? It's a modeled computer simulation. When I know the solubility of each one of these species, I can simultaneously solve for the dissolved concentrations of various solutes and their propensity to come out of solution. And then I can say that this sample has these supersaturation ratios for calcium oxalate, for calcium phosphate, for uric acid, sodium urate is another one. Cysteine can also be assessed as well as supersaturation. Now, there's some problems with modeling cysteine supersaturation. So when we're looking at a supersaturation of cysteine, we are essentially doing this experiment, okay? This will essentially allow one to actually calculate how much free cysteine is present in your solution and is and predisposing to the formation of cysteine precipitate, okay? Now, we think that modeling a supersaturation provides the advantage of knowing the big picture of a patient's predisposition to kidney stones. It turns out that the amount of sodium in this urine affects how much calcium oxalate precipitates, okay? So it's not a one-dimensional problem to solve, right? I simply don't need to know calcium oxalate and calcium oxalate content in this body system. I actually need to know what is the sodium concentration in this solution. I need to know what is the proton concentration in this solution, because that affects my calcium oxalate precipitation. I need to know how much uric acid is present in this solution, because that in fact also affects my propensity to form calcium oxalate stones. We'll emphasize that a little bit more. So using supersaturation essentially takes all of those influences into account in predicting the predisposition to precipitation of a crystal, okay? So supposedly it gives you more data, more understanding of the likelihood of forming stones. I have to use supposedly because we've never shown clearly that using supersaturations is markedly better than just trying to target how much calcium is in the urine and modifying that with the use of thiazides and low sodium intake, right? So one has to be honest about the fact that although we think it's really sort of scientific, multidimensional in understanding a stone risk through 24-hour urine stone profiles and then modeling supersaturation with a computer program called Equal To in this institution, that it's somehow, perfect science. It is not, okay? That is to say, let me take that to the bedside. If a patient has a supersaturation that's reassuring, and yet they're forming kidney stones, that is still actionable, right? You should be able to say, hey, I'm not perfect, even though your supersaturation looks good, because clinically you're not doing well. On the flip side, if my supersaturation looks non-reassuring, but the patient's doing well, leave them alone, right? Do no harm, because some of the interventions which we'll talk about actually can do harm. You can do too much of a good thing. You can give too much K-citrate and cause harm. All right, so we can therefore look at stone risk factors individually as we're managing a patient and sort of use it alongside the supersaturations. Don't just gloss over this stuff and just go straight to the supersaturation, and also don't over anchor on these things. So kind of use them both as you're making clinical decisions. And so things that would predispose a patient to more likelihood of stone formation is having relatively low urine volumes. That should be self-evident. Urine pH is a factor depending on the stone that you form, okay? So having some perfect pH is really not a sensible statement, because you have quote unquote perfect pHs for calcium phosphate stone formers. You have perfect pHs for uric acid stone formers, okay? We'll get into that. Most kidney stones are calcium oxalate stones, okay? And so we are often looking at this dimension of the 24-hour urine very weighted heavily, okay? We weight the urinary calcium excretion rate heavily. And, like Orson says, this is not a pregnancy test, so having a 24-hour urine of 240 versus 260 is not meaningfully different. Those are still relatively high. Let me make this point even further, that just because you got your 24-hour urine calcium below 200 or 250 does not mean you shouldn't continue to try and drive that urinary calcium lower, okay? If you look at calcium stone formers, you can see progressively less stone risk once you drive the calcium even lower, okay? Meaning a patient with a urine calcium of 180 has a meaningfully higher risk of kidney stones than a patient with a 120, okay? So if someone's forming a kidney stone and their urine calcium is 180, even though it's not, greater than 200 or 250, I'm still going to push on that potential modifying factor in order to reduce their kidney stone risk, okay? If they're having clinical events. If they're doing well, I might just say, life is hard enough as it is with all these dietary restrictions, just keep doing what you're doing, okay? Yep.
Is the cutoff from any evidence, odds ratio, 1.5 times of something?
Yeah, so again, that's where I'm speaking when I'm telling you these graded risks for kidney stone formation come from large data sets. For instance, some of these women's health, I would have to look for it and then send it to you. But people have looked at some of these longitudinal study of nurse populations and other women's health populations, where we're even giving calcium to patients and studying the effects of that on bone disease, cardiovascular disease. Some of these data sets were interrogated where we used, recall to evaluate stone risk in patients, and they found, again, graded risk of stone formation even in these numbers below 200. I'll send you the paper after the fact, okay? Urinary oxalate is another one. Again, you might see a somewhat of a hard cutoff, but that's not true as well. A person with a urinary oxalate of 30, I would still try and find ways to lower it, okay? If you're forming kidney stones, despite the other things. affecting someone's urine oxalate is challenging because of more dietary restrictions and is not clearly evidence-based. Nobody has really shown a good sort of data set that says if I lower your urine oxalate, you're going to have less kidney stones. Okay, it makes sense, and it is a push point, but it's not one that's grounded in evidence. Really, the evidence revolves around moderation of sodium intake, high fluid intake, moderation of animal protein intake, okay, and then a normal calcium intake, okay? It's unintuitive, but you do not want to restrict calcium in patients with calcium stone formation, okay? There's a couple of reasons why that is. Number one, calcium or oxalate is more readily absorbed when I lower calcium in the diet, okay? So one of the high oxalate foods is okra, okay? I like to put okra in one thing I make, okay? And I don't have kidney stones, but I don't want to have kidney stones. So when I have this big pile of okra, I actually drink a little milk with that, okay? Because having dairy with my oxalate load actually reduces the spike in urinary oxalate that follows a big oxalate intake. Or if you go to Penfield's, I think it's a Christmas party usually, and you have rhubarb pie, right? Rhubarb has a lot of oxalate in it. You know, have a little milk with that rhubarb, okay? All right, because it will reduce the oxalate content of your diet. So that just gives you the flavor that lowering calcium in your diet could be maladaptive because it might increase my urinary oxalate. The other reason why we don't like to restrict calcium too much is that when you have stone disease, you're at a higher risk, significantly higher risk of bone disease, osteoporosis. It's a risk factor for osteoporosis. There's some pathophysiology of why that is, but it makes sense then. If I have a stone former who has a risk for osteoporosis, I don't want to restrict their calcium too much, okay? So moderation of calcium intake, we generally say somewhere around 1,200 milligrams of dietary calcium, which is, again, sort of a moderate calcium intake, right? We don't tell people to calcium restrict. Was there a question?
Yeah, you kind of answered it, but oxalates in a lot of the healthy foods, and
yeah,
we already struggle with dietary nutritional discussions with patients, and so I was going to ask, is it just better to ask them to have a healthy amount of calcium servings rather than try and restrict those?
Yeah, so again, that I think kind of answered it. That being said, again, if somebody is, so I would say this is your second layer advice, right? You're going to focus on calcium for your calcareous meaning calcium stones. You're going to focus on reducing urinary calcium. You may affect citrate, okay? We'll talk about that, all right? But once you're starting to push on oxalate, that should be your sort of your second and third tier advice when you're still forming stones, okay? And there are things that really, again, somebody might not need to do, right? Like, do you really need the baked potato skins? That's where most of the oxalate is. If you really love your potatoes, take potatoes, but just take the skin off. And do you really love rhubarb pie? Or do you need oxalate? Or you need that okra in that frequency, right? Those are the things you should be asking. There's still a miso soup is really high in oxalate, okay? Do you need miso soup? Okay. Most people wouldn't live or die over miso soup. Maybe there will be, I don't know. I haven't met that person yet, okay? All right, so, but things like spinach, people are often sort of attached to. Almonds. Almonds is a pretty high oxalate food, and you can switch them to other nuts. You can say, well, do walnuts, okay? Just get off the almonds, because that has a lot, pistachio nuts, even peanuts, cheaper too. So those would have lower oxalate content than the almonds. If you can get someone usually off almonds. All right, so let's go to uric acid. Uric acid is, we'll get to in more depth. In general, when you form uric acid stones, I'll just anticipate this concept. I don't care about the uric acid, okay? I care about their urine pH. That is the push point when I have uric acid stone formers. Now, it turns out that if I have a calcium stone former, and again, I've done calcium, modified their urinary calcium excretion rate. I modified their citrate, which is a good guy. We'll talk about that. I've affected their oxalate or tried to get their oxalate down, and they're still forming kidney stones, and they have hyperuricosuriia, sort of fourth tier intervention. I might try and affect their urine uric acid to reduce calcium stones. Okay, so we have to make that make sense. Why does uric acid affect calcium stones? I believe I'll talk about that as we get to pathogenesis. We'll just gloss over that for now. Urine citrate is a good guy, okay? Urine citrate solubilizes calcium, okay? So the more citrate in the urine, the less likely calcium binds to less soluble oxalate and phosphate. So again, citrate outcompetes the oxalate and phosphate for calcium binding, and calcium citrate is soluble. So it's a good guy, all right? Sodium is generally bad. High urinary sodium excretion rates correlate with calcium excretion rates, okay? So volume, and let's make that make sense. Volume expansion increases or reduces proximal tubular reabsorption of various solutes, including calcium, right? Calcium absorption occurs throughout the nephron. It's regulated or it's fine-tuned in the distal nephron, but you have this, let's call it mass transport of calcium. There is some regulation of proximal tubular calcium handling as well, but much of this is influenced by effective circulating volume. Okay, so if I'm volume expanded by high salt diet, then I'm reducing urinary calcium reabsorption. More of it goes out in the final urine, and I get hypercalciuric. Okay, so sodium restriction is a critical intervention to reduce my urinary calcium, and then there may be a direct effect of sodium on solubility of calcium oxalate. The term that's used in physical chemistry is salting out, and so sodium might be the most intuitive one, where the more ions urine contains, the less it's able to maintain solubility for other species, okay? I'm sorry, I just got to check chat since I did do a biopsy on someone. Okay. All right, I think she can wait 30 minutes. All right, so would you mind answering this Epic chat for me? And just tell her that I will order it in 30 minutes, just small payment. Let me get it working and then I'll pass it off to you. Hopefully it works. Okay, so potassium is also generally a good guy, okay? So low urinary potassium is associated with a heightened risk of kidney stones. Maybe that's because there's a reasonable correlation between urinary potassium and urinary citrate. The more fruits and vegetables you have in your diet, the more, that's a base load in general, and those come as potassium citrate, okay? So even we use potassium, I think I mentioned this when I talked about the early concept of acid-base homeostasis. I talked about net endogenous acid production, or NEAP, okay? One can estimate net endogenous acid production by actually quantifying the urinary 24-hour urine potassium is equivalent in general to how much base is in your diet. So when you have a high urinary potassium, you have a lower net endogenous acid production. There's correlation between the two, and so people use a urinary potassium to estimate net endogenous acid production. Again, potassium citrate is alkali load from the diet. Sulfate is how much animal protein is in your diet, okay? Or if you're taking whey supplements, okay? All of that has a high amount of methionine, cysteine content of those sources of protein. is relatively high compared to legumes. So urinary sulfate is an estimate of how much dietary protein intake you have. So when you have patients who are, again, taking whey supplements for weightlifting, you'll find these really high sulfates. We had, I don't remember if I saw this patient with you, Alvin, but big, burly, muscular man, urinary sulfate was, clear, it was off the roof high, and it was because he was just putting in a lot of protein supplements in his foods. Urine phosphate is a modest risk factor. We won't belabor that. In general, calcium phosphate stone formers are not having that problem because of high urinary phosphate, but rather because of, could you please message and say, I'll get to it in about 30 minutes. It's because of their urine pH being too alkaline. Calcium phosphate stone formers are problems with alkaline urine pH. Urine magnesium is also a good guy. Turns out that magnesium oxalate is more soluble than calcium oxalate. Even so, we don't have rigorous evidence that giving people magnesium supplements significantly modifies clinical events. You can show improvements in supersaturation, but in small studies, pilot studies of magnesium supplementation as a means to reduce kidney stone formation, this was not a game changer. Okay, theoretically can help, but it's generally not a game changer. Urinary ammonium excretion rate tells you something about how much acid is in the diet. Why we low, and that can, for instance, inform why is this patient's urinary citrate low. Okay, we'll talk about that in another layer. All right, of this conversation. Okay, so let's go through, again, pathogenesis by the stone type. Okay, so a patient can be categorized as a specific type of stone former when they have a predominance of, well, even if you have modest amounts of uric acid in your urine, in your stone, right, as long as it's right a trivial amount. But if I have, reasonable amounts of uric acid in my stone, I'm often managing them predominantly as a uric acid stone former, right? You often have mixed stones. I guess I should start with that, okay? So you'll have, like, sometimes they'll even make some comments about the nucleus of the stone being a certain component. Often it's calcium phosphate surrounded by a shell of calcium oxalate. Okay, though sometimes you'll get that nuanced description of what is the stone analysis revealing. Okay, struvite, if you have much struvite in there, you're going to be managing this primarily as a struvite stone. Those are generally associated with urinary tract infections. Cystine stone formers, you're going to get targeting this element or this aspect of the pathogenesis by and large. So once you have really any significant proportion of your kidney stone consisting of uric acid, struvite, or cystine stone, you're going to sort of tunnel vision around those components of the stone as you're trying to address clinical events or reduce their clinical events. Okay, now for calcium stones, we somewhat arbitrarily say, okay, whatever is the greatest component of the stone, if it's more than 50% calcium phosphate, we're going to be managing them primarily as a phosphate stone former. If more than 50% is calcium oxalate, we're going to be predominantly managing them as a calcium oxalate stone former. There's gray zones there. Again, this is obviously not, once again, a pregnancy test. Okay? All right. So again, pathogenesis for calcareous stones, which is the most common stones, that means calcium-based stones, right, is going to be, you have to have some knowledge of what a Randall's plaque and plug is. Okay? So these are areas of calcification that are found in many stone formers. Okay, so when you look at a kidney and you find these medullary papillae that drain into the calyces, right, before those converge into, these are supposed to be calyces that converged into a renal pelvis, you have these medullary pyramids, right? These are often where there's a convergence of your collecting ducts, the ducts of Bellini, but also is where there is diving of these loops of Henle, the long loops of Henle. So if I were to magnify this, I would see that at the tip of these loops of Henle, you can often find these calcifications that actually start on the in the epithelium that lines. It's not in the lumen. It's in sort of the basolateral area of these epithelial cells that starts to form. Okay, and they can become large enough. They can actually rupture through and extend into the urinary space. Okay, as it's converging in these calyces. You can see these ruptures of calcification that is, again, rupturing and exposed to urine in this kind of early urine that forms in the calyces. So these can be the crystals, the seed crystals around which kidney stones form. Okay, now when I have calcifications forming in the collecting duct, we call those Randall's plugs. These are Randall's plaques. These are Randall's plugs. Okay, they turned out to be predominantly calcium phosphate. Okay, calcium phosphate is some of the, let's say, the earliest and most easily crystallizing or initiating crystals in your urine. Okay, subsequent to the formation of calcium phosphate, you can form even calcium phosphate has two forms. We call it brushite and hydroxyapatite. Hydroxyapatite is the same sort of form that makes up your bones. Okay, brushite is the sort of the earliest form of calcium phosphate that forms. It often then sort of changes in chemical composition to hydroxyapatite. These are both forms of calcium phosphate. Okay, all right, and then that can sort of be the nucleating crystal around which calcium oxalate forms. So that's often sort of a let's say a common theme or a common pathogenic path to the formation of calcareous stones more broadly. Okay, so these form seeds, and I've talked about all of these things. Okay, let's move on to the specific calcium oxalate stone. Again, that's 70% of stones. You don't always have, many times, you don't have an identity of what the stone is, right? They passed it and they didn't catch it, or urology didn't get it and send it for urine or stone analysis. I've certainly seen urology do procedures, but unfortunately we didn't send it for stone analysis, or it gets lost in the mail. They found it, they caught it, they mail it to you, and then it gets lost in the mail. We don't have this. So what I'm trying to say is that we are often operating in the area of uncertainty where we don't have a stone analysis. We just presume you're a calcareous stone former because I can see it on plain X-ray, which means that it's a calcareous stone, right? You have all the risk factors for calcareous stone former, and this is 70% of the stones are calcium oxalate stones. So I just presume you're a calcium oxalate stone former. Okay. Now, when somebody is forming calcium oxalate stones, you can often think of this as a problem with this equilibrium reaction, right? If I have excess calcium in the urine, I'll push towards calcium oxalate stone formation. If I have excess oxalate in the urine, that pushes towards calcium oxalate stone formation. So those are two push points. We focus primarily on calcium excretion rates. Sometimes we're focused on oxalate excretion rates. Okay. Now, again, I have citrate, which can compete for oxalate in forming a different end product, that is calcium citrate, which is more soluble. Okay, so that's how we can influence this particular equilibrium reaction. Again, we can lower calcium, we can lower oxalate, or we can outcompete oxalate with the addition of citrate. Okay, we can augment the urinary citrate excretion rate. All right, now many of these calcareous stone formers really just have hypercalciuria. that is the predominant problem. We often sort of summarize this as idiopathic hypercalciuria. Why do we call it idiopathic? It's because some people don't have an obviously high urinary sodium that's driving urinary calcium. Okay, let's talk about what are some of the potential pathogenic causes of hypercalciuria. Okay, so one could be that I have an excess amount of calcium absorption from the gut. Okay, and maybe these distill down to more and more. We're discovering that people have genetic variation around certain parts of calcium, steps in calcium homeostasis. For instance, some people have SNPs that are variants in the vitamin D receptor. Some people have genetic variants in claudins. Claudins are some of your proteins that mediate permeability at tight junctions of things like calcium and magnesium. Okay, we'll talk about magnesium disorders of calcium and magnesium wastage that are claudin disorders. So people have described, again, calcium sensing receptor variants, vitamin D variants, metabolism of vitamin D, so 24-hydroxylase. So there are all these little sort of interesting discoveries around what we've previously called idiopathic hypercalciuria. Okay, so some people might have, for instance, a variant in the vitamin D receptor, right, or vitamin D or 1-alpha hydroxylase, right, the vitamin D synthetic enzyme, right? And you can then explain why some patients might have higher than normal gut absorption of calcium, okay? So that's one potential reason that people have hypercalciuria, okay? Others might have hypercalciuria. Even if you put them on a low calcium diet, they continue to manifest hypercalciuria. And so these patients may have a problem with calcium handling by the nephron. Okay, so this would be an absorptive, AB, B as in boy, absorptive hypercalciuria. People have described this as a calcium leak hypercalciuria. Okay, so my kidney has some problem with paracellular divalent ion transport, and I develop this persistent calcium leak. This may explain again why we see higher rates of bone disease, osteoporosis in calcium stone formers, right? If you have persistent calcium leak, it makes sense that you will be predisposed to osteoporosis later in life. This may be one of the reasons why that is, okay? And again, that may be at root a problem with the calcium sensing receptor, okay? An activating mutation of the calcium sensing receptor might, again, evidence hypercalciuria. Now, these patients would be the last sort of, hypothetical cause of hypercalciuria. These patients are predisposed to bone resorption. So absorptive hypercalciuria, calcium leak hypercalciuria, and then resorptive hypercalciuria. Okay, these patients are predisposed to high bone turnover, and they liberate the calcium to the ECF, the kidneys dump it. So that would be another reason why patients may be predisposed to osteoporosis. Okay, once again, we don't want to calcium restrict our patients for all of these reasons. Other causes of hypercalciuria we talked about. Sodium intake is a modifying factor for hypercalciuria through its propensity to volume expand the individual on a high calcium diet. Excuse me. Obviously, if I have primary hyperparathyroidism, if I have sarcoidosis or other disorders of excess calcitriol, sometimes I'm seeing actually in the community, people are just overdoing it with vitamin D. I'm, in my stone clinic with hypercalciuric patients, I'm not rarely seeing patients with a vitamin D level of over 100. And they're just, people think too much of a good, or lean into too much of a good thing. Or I'll even say a questionable thing. I'm often telling fellows, forget about the vitamin D, right? That's the least important thing we're doing in clinic. All right, so metabolic acidosis is another factor that may cause hypercalciuria. It also can reduce urinary citrate. We'll talk about that. So if you have an acidotic patient with calcareous stones, they may manifest hypercalciuria, and they will almost certainly have hypocitraturia. We'll talk about why that is physiologically almost certain, okay, if you have metabolic acidosis. How does metabolic acidosis cause hypercalciuria? Remember that bone is a big buffer system. Calcium hydroxyapatite is basically calcium, phosphate, and bicarbonate. And so if I have a chronic acidosis, I am demineralizing my bone. And if you're a child who's growing, who has an RTA, you'll be falling off your growth curve until you give them base. You just put them on sodium bicarbonate, and then you'll notice that their growth curve kicks up. Okay, that's just highlighting the importance of bone as a body buffer. Okay, there may be some direct effects of metabolic acidosis on TRPV5 activity in the distal convoluted tubule. So I'll just give you that visual. TRPV5 is an apical membrane transporter in the DCT and mediates calcium transport in the distal convoluted tubule. Some people have shown that acidosis will downregulate TRPV5 activity. Okay, so maybe there's again a direct problem with calcium handling through metabolic acidosis. Again, we talked about hyperoxaluria being a second-tier intervention, second or third-tier intervention for the patient who persistently has kidney stones. It would not be your first intervention unless it's off the chart high. Let me say that sometimes we diagnose primary hyperoxaluria in a calcium oxalate stone former. Okay, so you can have genetic disorders of oxalate metabolism that predispose to nephrocalcinosis and calcium oxalate stone formation. These patients will have urinary oxalates that are greater than 100. Kelly taught us about oxalate in a patient who was taking massive doses of vitamin C. So you may have patients who are going nuts with vitamin C, and they may have huge amounts of urinary oxalate. So sometimes it's the first thing you do in these, let's call it oddball patients. I was going to say cases, but I'll call them oddball patients who are just going nuts with these supplements. Okay? But again, sometimes it's a genetic disorder. Now, the dietary sources, the brief one to sort of be aware of are, in general, protein beans like black beans. Red beans are going to have high urinary or high oxalate content. The potato skins, almonds, cashews, these are, there's plenty of other options. Rhubarb I mentioned, so keep that in mind when you eat rhubarb pie. Spinach, okra's on there, chocolate's on there, bran foods are on there. So you'll see some of the ones to know off the top of your head, okay? When you're doing a quick dietary review. You can find even longer lists that have, cover all the corners of things that some individuals overdo it on. Vitamin C we talked about. Primary hyperoxaluria we talked about as things that can increase urinary oxalate quite dramatically. So you need to ask these of your calcium stone formers with high urinary oxalate. Sometimes they don't report it. People have shown that there is oxalobacter in the gut, which actually metabolizes oxalate in the gut, such that if you have reduced oxalobacter expression, you can have high intestinal absorption of oxalate and then hyperoxaluria. So you can see this even after antibiotic exposure. So doing a 24-hour urine after somebody has, a course of antibiotics could affect their urine oxalate in a way that is not reflective of their normal state. So keep that in mind. People have tried to modify intestinal oxalobacter content through probiotic use to try and reduce kidney stone formation in calcium oxalate stone formers, but that has been disappointing. Okay. Malabsorption of fatty acids are another classic cause of calcium oxalate stone formers or calcium oxalate stone formation. So some of our post-bariatric surgery patients have this problem, calcium oxalate stone formers. Now, it has to be the malabsorptive bariatric surgeries. So those are the Roux-en-Y's. It's not the ones that have just gastric restriction procedures. Gastric restriction has some loose association with kidney stone formation, and that may be simply because they can't drink as much, because they can't tolerate large amounts of things in their stomach. But by and large, the risk factor is the bariatric surgery with a Roux-en-Y. Okay? Why? That's because the fatty acids that are being malabsorbed, not just the restriction of the distension of the intestinal tract, but it's actually the fatty acid malabsorption that causes the problem, right? Fatty acids are negatively charged, right? They're cleaved from that glycerol backbone. They're now negatively charged in the gut, right? After you have lipase acting on it, lipase in the gut, right? Lipase coming from your pancreas. It's squirting, lipase into the lumen. It starts cleaving the triglycerides into fatty acids. Fatty acids are negatively charged, right? Calcium is positively charged, right? So calcium starts to bind fatty acids. It's no longer able to bind the oxalate and reduce its absorption. Okay, so fatty acids flowing distally in the gut will bind up calcium. Calcium can no longer sort of chelate the oxalate, so your urinary oxalates go up. Okay, also this fatty acid malabsorption may also kind of affect the intestinal epithelium, making it more leaky and absorptive for calcium and oxalate. Okay, so those are the two mechanisms whereby fatty acid malabsorption can cause this predisposition to high urinary oxalates. Okay. Hypocitraturia. So again, we're talking about risk factors for calcium oxalate stones, right? So hypercalciuria from all of these potential mechanisms is a risk factor. Hyperoxaluria is a risk factor. And now low urinary citrate is a risk factor for calcium oxalate stones. Yeah.
What is the exogenous calcium supplements increase risk for stone? But the diet, you mentioned the dietary risk.
Well, okay, so that's a good area of controversy that we should talk about. So the question is, why does calcium supplement increase stone risk versus dietary calcium intake? Okay, this comes back to the Women's Health Survey, okay, where we're looking at the effects of calcium supplements on various clinical events, right? And so they looked at this longitudinal cohort, and they looked at, from recall, how many of you take calcium supplements and how many of you don't. And so when looking at that data set, they found, well, calcium supplements, they seem to reduce osteoporosis risk, but they may have a weak signal for increased cardiovascular events, and they seem to have a signal for increased kidney stones. Okay? And so it's this guilty by association where we suspect calcium supplements are bad, but we also have this competing data that says moderate, or let's call it medium calcium intake, not calcium restriction, is good for calcium stone risk. Okay, and then it makes sense because it binds oxalate. So we reconcile these things without knowing clearly that dietary calcium versus supplemental calcium does something different to the patient. We don't know that. We have this indirect conclusion that this Women's Health Survey says diet or calcium supplements may have these bad things, okay? But we have other data that says, well, just moderating calcium intake through dairy and actually sardines, and eating the bones of the sardines. And soy protein actually has a fair amount of calcium in it. Calcium through um, supplemental orange juice. You'll see the supplemented, calcium fortified orange juice is enough. Yogurt are some of the things we tell our patients to eat some more yogurt. So we often say eat more dairy because we're worried about the Women's Health Survey. That's the reason why. Now, if a patient says, well, I can't eat dairy, I get all this gastric distress, and I need to bind oxalate because they have, for instance, fatty acid malabsorption. Absolutely, I'm using calcium supplements. Okay. So don't paint yourself in a corner and just kind of block it out in your mind as a therapeutic. Okay. All right. So metabolic acidosis from any cause, even subclinical metabolic acidosis. What is subclinical metabolic acidosis? Well, incomplete RTA, right? How do we define that? That's a patient who has a normal serum bicarbonate, but their urine pH is on the alkaline side more often than not, right? So often these patients have a subclinical acidosis. What does that mean? That means acid intake through diet is exceeding my urinary acid excretion. Well, how do I maintain a normal serum bicarbonate then? I demineralize my bone, right? My bone can be a buffer that I consume over time. I can maintain a serum bicarbonate that's normal, even though acid intake exceeds acid excretion, right? I'm in positive acid balance, right? But I keep my serum bicarbonate relatively normal. That would be an example of subclinical metabolic acidosis. Even when your serum bicarbonate is normal, you'll see urinary citrates that go down before my serum bicarbonate drops. That's why I said, again, almost certainly if you have an acidosis, even subclinical acidosis, urinary citrates go down. All right, so let's talk about the physiology of where that occurs. That occurs in the proximal nephron. Proximal tubular citrate handling is modified, as well as intracellular citrate metabolism. So here we are in this number 2 of 2 of the proximal tubule, where I have this sodium citrate cotransporter, right? Notice that it is more likely or is more readily transporting this divalent form of citrate, okay? So when I have acidosis, citrate is more likely to carry a proton and exist in this divalent form, and so it is more readily reclaimed. So acidosis creates more divalent citrate. More divalent citrate enhances urinary citrate reclamation. Enhanced urinary citrate reclamation means less citrate escaping into the urine. Okay? There's also intracellular processes that are upregulated in the setting of metabolic acidosis. One of the rate-limiting steps of citrate metabolism is an enzyme called citrate lyase. It is also affected by pH. When pH is more acidic, I metabolize more citrate in the cell. I enhance my reclamation of citrate. So metabolic acidosis increases citrate. Now I'm going to ask you a question. What would K depletion, this is coming to you, Kelly. What would you expect K depletion does to urinary citrate? K depletion, I'm going to step with you, does what to intracellular proton concentration? If K is leaving the cell, what?
Then it's going into the cell and increasing lipogenesis.
That's correct. We increase proton concentration inside the cell if K is leaving the cell. Okay, if proton concentration in the cell goes up, what happens to citrate lyase activity? Goes up, right? It metabolizes more citrate in the cell. So you tell me, what does K depletion do to urinary citrate excretion? It will go down, okay? So you should pay attention. And let's suppose you put someone on HCTZ. and they get hypokalemic. Their urinary calcium goes down, but their urine citrate goes down. How are you going to address that? Well, I'm not going to give them potassium citrate. I don't have to. I might just say, okay, I'm going to give you KCl, or I'm going to switch your hydrochlorothiazide to triamterene hydrochlorothiazide, right? It turns out, even though we don't think about this enough, the use of amiloride and triamterene also lowers urinary calcium. Okay, you can use those to lower urinary calcium. Basically, if I, and then some people have shown that, well, I guess it's variable. Urinary calcium excretion rates may also tend to go down with SGLT2 inhibitors. It's not a consistent finding. There's differing effects on urinary citrate with SGLT2 inhibitors. I can show you the papers. The net is that some people believe that SGLT2 inhibitors may reduce your predisposition to calcareous stone formation. Okay, but the story is muddy, because depending on what your pH is, your urinary pH is, there's differing directions that your urinary citrate goes. Okay, so it's a muddy area. If you're really interested in, I can share a recent paper that elucidates some of that. Okay, so let me just say that even though we look for excuses to give SGLT2s to everyone, there's some weak evidence that it might reduce kidney stone formation. It is not, it should not be part of the usual enthusiasm that we have for SGLT2s for every affliction under the sun, including, my toe hurts. Okay, so what was I saying? Yes, so essentially, remember, if I block transport in the thick ascending limb with a loop diuretic, I am going to tend to enhance calciuria. Okay, so urine calcium goes up with loop diuretics. Okay, so that's not helpful. But if I block any of the segments other than the thick ascending limb, okay, I guess I'll put it that way, I tend to cause volume contraction without increasing urinary calcium excretion rates. And in fact, urinary calcium excretion rates can go down because I'm volume depleting you, right? So what does that do to proximal tubular calcium handling? Gobble it up, right? More calcium reabsorption in the proximal nephron. So volume depletion through anything except for a thick ascending limb transport inhibitor could reduce your urinary calcium. So we forget sometimes that giving an ENaC blocker can actually help reduce urinary calcium, but it is an intervention that one can consider. Okay? Questions about the use of more distal segment transporters for hypercalciuria? I guess I went backwards, back to hypercalciuria, but I think emphasized enough. Hypocitraturia is a modifying factor. Once we talk about calcium phosphate stone formers, we often do harm in calcium phosphate stone formers by giving too much K citrate. We'll talk about that next time. I'm going to not get to that today. But one way that you can do no harm in a calcium phosphate stone former is to make sure they're not K deficient. Right? By closing a K deficiency, I can try and increase urine citrate without causing more alkaline urine through potassium citrate, right? Alkaline urine is bad when you have a calcium phosphate stone former. So one way I can, again, help increase urinary citrate without alkalinizing the urine, which would be bad if I'm a calcium phosphate stone former, is close the K gap. Okay? Other ways that individuals can become hypocitraturic is this subclinical acidosis from just taking in too much animal protein. Remember, that's an acid load. We talked about the effect of K depletion. on urinary citrate excretion rates. And then here, I'm elucidating some of the final sort of elements that can predispose to calcium oxalate stone formers. That's hyperuricosuria is one of your, again, late interventions. If you have nothing else you can do for the patient and they're still forming stones and their uric acid is high, you can actually give somebody an allopurinol to try and reduce calcium stone formation. Okay, how does this all make sense? Well, uric acid can be the initial nucleating seed around which a calcium oxalate stone forms. There's also an effect of uric acid as a antagonist of stone inhibitors, right? So this uric acid, some thinkers here in this space say a colloidal form of uric acid can start to bind up some mucopolysaccharides, including things like TAMS horseful protein, which actually inhibits stone formation. That can be affected by the uric acid content of your urine. So if a last-ditch effort, we can sometimes affect hyperuricosuric. We can affect calcium oxalate stone formers by addressing their hyperuricosuric. Okay? Acidic urine may increase the predisposition to stone formation by making it more likely to form these uric acid seed crystals or nucleating crystals. Okay? Questions about calcium oxalate, the most common stone formed? If not, we'll get to calcium phosphate, uric acid, struvite, and cystine stones, and then go on to some of the clinical management of kidney stones next time.